must be involved in the class. You shouldn't be driving or doing any other distracted things during our class, just to make sure everyone is safe. This is something new with us today. We're doing a live presentation. I'm going to let the distinguished speakers in the back of the truck introduce yourself in just a minute. At the very end of the presentation, remember, I'll ask you to type in your email address and your name toward the end. If you have questions, please just type those in the chat. We want to make sure that we're able to control all the audio and no feedback. We have several people that it's still showing that we can't promote to panelists, so you may have to do something different on your device to accept the invitation. So with no further ado, I'm going to turn it over to the gentleman out in the EMS bay.
Hey everyone, thanks for joining us. We'll do full introductions here in a minute. I'm Jared McKinney. We decided to do something a little different this time. Instead of being in an office or in front of the computer on Zoom, we thought we'd get out in the truck and try to mix things up a little bit. So a few disclaimers. One, you'll notice we don't have masks on. We are all vaccinated, so that's why we're unmasked. Two, Liz mentioned this. If you have questions as we go, this needs to be interactive and we want it to be interactive. So please put questions in the chat. We can go whatever direction you want to get what you need out of this. And then we'll do some introductions here, and then we'll kind of talk about the why behind what we're doing. So again, I'm Jared McKinney. I'm one of the faculty in emergency medicine. I'm also the medical director for critical care ground event medicine and our ground ALS service. We also have Dr. Stephan Russ with us.
Hey, my name is Stephan Russ. I'm one of the chiefs of staff at Vanderbilt. I work clinically in the emergency department, and I'm really looking forward to this. We've got some incredible clinical horsepower here, so learning a little bit more, and I'm going to share some of my thoughts about Airways as we go through the event today.
Hey, I'm Kevin Ha. I'm an associate with Vanderbilt Emergency Services and Vanderbilt Emergency Medicine, and I'm a clinical associate with Lifelight, and I'm happy to be here with Dr. Russ and Dr. McKinney.
So we're going to do some talk about airway management and rapid sequence. This
Dr.
could
McKinney,
be probably a 2, 3, 4 hour lecture, and we're kind of really whittle it down to something super important that we developed that we think moving forward will enhance the safety margin of this. I think when you think about intubation, when we do it in an austere environment, whether that's on the street, in a bathroom, in the back of a truck, in the back of a helicopter, there's not always as many hands as we have in the emergency department, and often situations a lot more difficult, quite honestly. So having a methodology and a process for how you, that is, it's not just the process itself, right? And learning how to intubate, it's the critical thinking that surrounds it. Why are we doing this? How are we going to do this? And how do we limit the potential morbidity, mortality associated with this procedure? So Kevin, correct me if I'm wrong, in 2013, we launched into an endeavor to look into doing an airway checklist. I'm going to let Kevin kind of really talk about the why behind that. But this has been a big step for us in the emergency department. We do it every patient, every time. Who?
Change to speaker.
Oh yeah, change to speaker view, sorry. So we'll talk about kind of why we went through that process, the outcomes we've seen, and then what it means for you all out in the field. So with that, Mr. High.
Yeah, so God, it's been, like Dr. McKinney said, 7, 8 years ago, we started a move towards using a checklist type system prior to after being flying for 14 years. You know, in aviation, we're used to using checklists. It's part of our safety culture, and so I was very, very excited about that. We developed both. We're going to show you. We've got a pre-induction checklist. We've also got a prior to patient arrival or prior to procedure checklist. And Dr. McKinney kind of brought up, you know, that we work in a tough environment outside the hospital, and along with that goes also a duty on our part. We are in an austere environment, but that doesn't mean that we're allowed to kind of cut corners. So using this checklist system both before you induce the patient, and as far as getting yourself, getting your team, getting things ready, and then running through a set of items that we're going to discuss in depth is really, really important. This is something we published on, and we've shared our checklist with a lot of other organizations and entities across the United States.
This is Stephan. I do want to say that if you've gone to the grocery store and your entire life you've never forgotten a thing, maybe you don't need to use a checklist. Everybody else has got to use a checklist. I'm a huge believer in this. I watched as a trainee a very, very good physician set up for an RSI, do the RSI, and as they pushed paralytics, realized that she didn't have a handle for her laryngoscope. And that's a really long 2 to 3 minutes while you're rummaging around looking for a handle. I approach this like skydiving. I think that's a really good analogy. You only get one chance. It's all over in a couple minutes, one way or the other, right? And it's a life or death thing. So I think we need to approach this the same way for our patients. We're pushing them out of an airplane when we push paralytics. And we want to be sure that we've got them safely. And a checklist goes a really long way towards doing that.
And I think as Liz gets ready to pull up some slides that we're going to go through initially, I think I will freely admit, and I think Dr. Russ will admit this too, when we do this in the department, we have a lot more hands. We have, 10 people in the room. It's 74 degrees in the trauma bay. The bed's the perfect height. I have great lighting. I say all that to say we have a lot of resources and we still go through this checklist. I think we all acknowledge that when we do this in the out of hospital arena, you have limited hands. And so that's why it becomes even more important to make sure, to Dr. Russ's point, we do this really well. We do the same thing every time, and we don't cut corners and miss things. So Liz, if you want to pull up some slides, I'll throw it back to Kevin to talk more about
Yeah, and while
this.
Liz brings those slides up, so I'm a lot older than both Dr. McKinney and Dr. Russ. And the first time I picked up a laryngoscope was in 1986. And I have been a part of every type of airway disaster you can. I've either watched it unfold before me or have been a part of the problem myself early on in my career. Everything from, I'll just take a look, to, well, if one attempt is good, then 7 must be better. And, we, as an organization, we moved past that a long, long time ago. We're going to be sharing mics, it looks. Okay, so Liz just brought up a slide, and it kind of goes over what Dr. McKinney, Dr. Russ have talked about our use of checklists in and around airway management. Liz, go on to the next one if you don't mind, please. I mentioned and brought up the use of checklists in and around aviation. If you've never heard, you can go on YouTube and look at the Miracle on the Hudson, Cactus 1549, and listen to the cockpit audio, and you can hear them running that checklist. They're not panicking, or the opposite of panicking and raised voices is actual silence, but they're not doing either one of those. You can hear them running this checklist. And Liz, go on to the next slide. Every emergency procedure in aviation has got something that is easy, it's quick, it's simple to read, there's zero ambiguity associated with it. And this checklist type culture that you find in aviation is what we wanted to build into our system. And this works really, it's just like, it's perfect for life flight, because we've already got this aviation component to your job. Why not just move this over into the clinical arena? And that kind of brought us to where we are now. Liz, go on to the next one, please. All right. So this is something that what we do is we charge whoever that we're going to call that person the proceduralist. And I don't know if different people use different things for this. And as Dr. Russ mentioned, this whole, if you've ever gone to the grocery store and have ever forgotten something, you're kind of, you're guilty with this. but this gives you an idea of every item that you need to have ready to do an intubation. So give you our general rules with equipment and being ready. So Jerry, you can kind of back up. So we've got a lot of equipment in here, but if you'll kind of look at things and how we're positioned here in this vehicle. Okay. All right. Well, I'll describe it to you. Yeah. So there's like things to do as far as equipment that me and my partner can't both touch without getting out of our seats, or that I can't visually see is not ready. That's one of the most important things about getting your equipment ready prior to that. And then also knowing, I mean, everybody knows, but you've got to know your bag or wherever you're keeping this equipment, you've got to know that backwards and forwards, be able to find it under all kinds of conditions. And it should be easy and almost mindless.
Can I make a quick comment about that? We go through all these steps, and there's all these prediction rules and models that we do to figure out who's going to be a difficult intubation. But I think the reality is we've all had and so I think we can use all of those prediction tools, and they're important. And I think it's always important to look and say, is this person going to be a difficult airway? But I think it's equally important to every patient, every time you do this, have all of these things available, right? It's the time where you don't expect it and you don't have these things available that'll get up and bite you. So, 100%, if you look at somebody and they have all the predictors of being a difficult airway, it's going to heighten your awareness. At the same time, if you look at the 20-year-old who's thin and looks like they have a perfect, don't get fooled and not have all of your equipment out, because that's the time you'll end up needing it. So,
yeah. So here's just a thing on prediction in general. Prediction works best in an elective environment. We're not in an elective environment. That doesn't mean you should not use some of the predictors that Dr. McKinney's talking about. If you've ever heard me speak on this topic, every one of them is difficult. Every one of them is these patients is, I'm going to plan for the absolute worst thing. I'm 100% committed. When the plunger hits the bottom of the sucks, I'm all in. I'm all in every time. I'm willing to go all the way every time. And our effort as a group is going to be, we're going to completely dominate this. Our first attempt is our best attempt. There's no, like I said earlier, I'll let Dr. McKinney just give it a try while Dr. Russ and I get the equipment together. There's none of that. We're going to completely dominate this. Once we decide to go there, we're all in. So prediction's good, but it's got to be part of your mindset. If you want to learn just two predictors that, like, when to get scared, when fluids are involved, blood or vomit, people like can't oxygenate, or I'm heavy with oxygenation. Those two people, scare me a little, or more than they used to. But those are two kind of good. Just if you only had to know two, it's fluids, oxygenation. Dr. Russ, you got anything on any of these? And because our next slide is going to have our mat that I want to talk about.
No, just continue along this theme. There's no easy skydive, right?
Yeah. No. Yeah.
I want to know that parachute's good every single time. And remember, you're not the one jumping out of the airplane. You're pushing your patient out. So it's really important to know this. Okay.
All right. So, hey, Liz. So I tell you what, Jerry, if you can, they're looking at the slides, right? All right. So I'll tell you when they can see me. Okay. All right. So I'm in the airway seat. I'm in the airway seat of the truck. Dr. McKinney, Dr. Russ are over here to my left. And so I'll talk a little bit about equipment. Okay. So if we're going to induce this patient here, here's what's going to happen is every one of us can see the monitor. The patient before I can see the monitor. All of us can touch.
Hey, real quick.
Yeah.
Liz, go back to the main view. Let's cut away from the slides for a minute, kind of while we walk through this process a little bit, so we have it on the big screen.
There we go. All right. Okay. So here's just some rules of thumb, and these apply to I don't care what vehicle, fixed wing, rotor wing, ambulance, whatever. Okay. So equipment that I cannot touch, I have to be able to see it, but if I can't touch it, is not available. All right. I want to make sure that my teammates can have access to the patient, and they can see the monitor, and a minimum of Dr. McKinney sitting next to me. So he and I should both be able to touch the equipment, and like just, not even not if we've got our seatbelt shoulder harnesses on, we be able to just to lean and grab something like that. And that's my like kind of global rules on equipment. And I don't, one other little safety thing I'll do, and we'll talk about that in an induction, but anything else on that one? We'll go with the dump mount.
Yeah, no, I think it's important, right? Monitor and reach. You have your suction and reach. You have all your airway equipment and your drugs where you can readily get them. Your backup devices are not tucked away in a cabinet. They're out. They're ready to go. You have your syringes out that you need for balloons, et cetera. So that way, to Kevin's point, once you start this process, you're reaching for what you need. You're not having to get up, and it's all right there. The other thing I would stress, and then we're going to hand it over to Dr. Russ, is when you do this, just get in the habit of putting those things in the same place every time. I think a lot of this is muscle memory. The procedure itself is a lot of muscle memory. And so having those things in the standard place for you, whatever that means, you'll know kind of where to go when things really start getting bad. And when your adrenaline starts going up is when we make mistakes. And the more you have things in a place that you're accustomed to, and you've gone through this 100 different times, the easier it's going to be. So
it turns out that when I get gloves that are slippery with blood or other fluid, I have a really hard time opening some of the things like the end of the bougie. And so part of my prep is making sure I crack open, not all the way, but just have those two ends of things like extra stylets pulled apart so that I can grab that packaging and open it, because otherwise it takes me 30 seconds of fumbling and everything's blood covered and I'm grabbing at it with my teeth to try to get it open.
So Liz, let's go to the dump mat, to that slide, and we're going to some of it's self-explanatory, but what I like about, I don't, if you're having a hard time understanding me, it's my Southern accent in public school coming out. But what I'm saying is dump, D-U-M-P, dump mat. The name comes from that. It's like I can take everything out of my bag, dump it onto this mat, and it's just like a child's play mat. If you've ever seen this, if you want to know, teach them to fork, a little diagram like this. And so we came up with this mat, and I'll tell you, is I actually saw a group of emerge docs from Australia, their helicopter EMS out of Sydney, that were using this, and it was made out of some kind of, it was paper, but it was thick, and they just lay this thing down wherever they're going to do an intubation, and this is where they put all their equipment. So I built this thing, and we now have this within the facility, and so it gives you all the outline for everything that you're gonna need, and you absolutely know for sure that you have this equipment on hand, and that everybody can see it. I don't know. Do you like that?
yeah, absolutely. And when you go into our trauma bays, and when you transport somebody, and we're happy to show you this to you in real time, we have all this equipment set out. It's not in drawers, it's not in cabinets. We have this equivalent mat set up in each bay where we do intubations. And if we're not in the trauma bay, we set it up in whatever room we're at. So again, it's the point of, if you do the same thing every time, you get comfortable doing it. And that's how we minimize errors.
So, hey, Liz, can we go back and do like full camera? Or I just want to make sure people can see all of us. And if you don't mind, Dr. Russ, hand me that bougie. And I tell you what, so things like, I don't know, it's good. I've got two physicians here with me. This used to be a rescue device. This was a backup device. I don't know. It's kind of a primary device now.
Yeah, get comfortable using bougies. Absolutely get comfortable using bougies.
Yeah, I think it's kind of a primary device now. All right, so I might not leave this on the mat. I might have my partner like have it in their hand where they can hand it to me. I've seen both of them. They're working inside the ED, and I watch Dr. Russ. He'll like stick this thing while it's in the packaging, not out of the packaging, like up under his arm like this. Just have this thing close by. The other thing is I always like to think of is, okay, we're going to make an attempt, and let's going to say that the attempt is not going to be successful. When the blade comes out of the mouth, that tends to separate. You'll see how well. Let's see really how good you are, because what happens next can look like a beautiful orchestrated event, or it can just be mayhem. But the next thing you need to reach for is this, this, and this. So these 3 items, this is like the fire extinguisher in your house, the CO2 detector, the life preserver, the whatever. I don't even have to ask Dr. Russ. I know he knows where the emergency exits are in every aircraft he flies down when he flies commercially. This is whatever your little pet peeve safety thing is, this equates to that. So I'm really, really big on how I store the mask, the oral airway, and the nasal airway, and that I be able to get to them really quickly, because this is going to be, if I get into trouble, this is going to be what I'm going to reach for first. So I want, if I'm sitting here, sitting in whatever type of vehicle, I need to be able to reach this, see it and reach it. And so do my partner or partners. What you like that?
Yeah, I'll tell you, starting to say their LMA is going to be their go-to instead of bagging somebody. And I think if you're really good with an LMA, that's probably fair. You need to have used it some and be comfortable with it. But it's a good backup plan as well. You just need to enunciate to everybody in the room. Everybody needs to know what your backup plan is going to be.
Yeah. No, it's good. All right. So, hey, Liz, the mat real quick. And you'll notice on there that we have got like a tube bigger and smaller than we'll need. The bougie, Dr. Russ mentioned having an LMA or some kind of supraglottic, an iGel, a King, whatever. You need some kind of supraglottic, and then you need the other thing, and I have it, but I don't have it. Is working suction, and when I mean working, so if I'm working in an ambulance, usually the noise isn't that bad versus in a rotor or fixed wing aircraft. But I'm going to actually measure that if I touch that thing to my cheek, it'll like pull my cheek away. Like it's like really no joke working. I like to take that and either slide that under the patient's right shoulder or slide it under the right rear part of the mattress. Or if they're on a spine board, I'll put it up under the spine board. And then I'll have all my other stuff. I like, if I can, the other little trick I'll do is I'll just take an endotracheal tube and stick it. I actually like a pair of eyeglasses. Look at me. Their ear and stick the curved part of it down in there. Then all I have to do is reach, grab the tube, and deliver it. I think that's kind of it on equipment. You got anything else? We can talk pre-induction where you can take a deeper dive. So Liz,
let's go to the pre-induction.
All right, Liz, advance our slide there, please, ma'am. All right. So this is before we induce. What we're going to go through, and this checklist is built to be is what's called a challenge checklist. Is that's a person, somebody else, usually the proceduralist, is going to verbally confirm that. It's like asking a question and like, are you, Dr. McKinney, you going to get lunch after we get through? He has to either say yes or no. Yes, absolutely. So every one of these things we're going to go through, and so the first one is this pre-arrival checklist complete. That means is all of our equipment ready, and that's it. That's pretty self-explanatory. All right, we've got on here airway plan confirmed between trauma and ED attending, but what this really alludes to is that we have a plan, and the plan has been verbalized to the team. And so tell us about what does that look like?
Yeah, so for this is depending on how many hands you have in the back, right? It's between you and whoever is in the back of the truck, aircraft, et cetera, with you. And, the reason for doing that is multifold. One is it helps you in your mind think about, okay, what is my exact plan? If I'm not able to intubate immediately, blade comes out. Am I doing a BVM? Am I doing a supraglottic? And then importantly, what am I going to change the second time, right? So that, I'm going to DL. Okay, I'm going to DL, but if that fails, then what? The other thing that does, not only does it, every time you do this, get you in this sequence of doing it, so the next time you do it, you're even more ready. The other thing it does is for the people that are in that unit with you or on that scene with you, also know, right? So they know, all right, if that blade comes out of the mouth and the first attempt failed, I know that the next step, excuse me, is going to be an LMA, and they can prepare for that. So you have extra hands, use those. You can have somebody that's able to, again, we said have everything in reach, can grab that LMA, can give you the LMA, and you can keep going. So Dr. Russ.
Yeah. There are occasions where we're going to decide that we got to move to a cricothyrotomy quickly. There are other things going on with this patient. That's the great time to sort of verbalize that. Who's going to do that? There's a lot that can go on there, but everybody should know the plan.
Yeah. So one of the things with planning and like I'm a little, I'm older, more experienced. I've done this before. So I usually typically wind up being a little bit further back from the procedure, and somebody else is going to be doing the procedure, and I'm an extra set of hands. But I also kind of tend to critique what's going on, at least in my own mind. And I'll tell you, so my level, how comfortable I am with you is directly related to how well you communicate. And so when I'll have a paramedic, a transport nurse, a resident, or a faculty member that will verbalize an airway plan that includes a bailout number that's, as Dr. McKinney talked about, if we're not able to intubate on the first attempt, our next step is X. I am like, yes, okay, versus, hey, let's just give the drugs and we'll go from there. Y'all ready? That's not a plan.
One of the scenarios that can happen a lot is you have a flight crew and a ground crew in an ambulance together, and they haven't worked together before. That is a great time to be doing that. We had the NASCAR event over the weekend and worked together with WEMA, and I got to give a shout out to those guys and gals at WEMA. Were really amazing during NASCAR. We did have to intubate a patient. There were 5 or 6 people in the back of that ambulance. That is a great time to have lots of very clear communication, right?
Yeah, so that's so step one, right? Confirm your plan, confirm it with yourself, confirm it with everybody else who's in that scene unit wherever you're at. Step 2, as you can see, is IV functioning, right? And that doesn't just mean it's free flowing and it hasn't infiltrated, right? But it also means blood pressure cuff is on the opposite arm. The last thing you want is to start pushing meds and have that automated blood pressure cuff go up. Not only do the meds not get delivered, but then off and you lose that piece of monitoring. So
yeah, and so we want to have at least one good point of IV access. I mean, 2 is preferable, but we're going to confirm that we've got an IV, and that's going to be the site or point of access that we're going to use to deliver meds. All right, so next one is drug or RSI drug dosage confirmed and drawn up. So those kind of come into, I'm old enough to remember when we used to do pre-treatment stuff. We're out of that now, praise the Lord. But it's kind of going to come down to sedative, hypnotic, and paralytic, and that's going to be whatever within your set of protocols, whatever set of boundaries that you have. My only thing here is that choose wisely and get the dosing right. Be really careful with these reflex doses of drugs. Like, people in my practice, I'll hear 150 of ketamine and 150 of sucks being used a lot. And, somebody, like maybe my size needs 200. So be careful on the dosing.
Pediatrics, right? We definitely have to get the dosages right. But to Kevin's point, it's true in adults as well. It's not one size fits all. So know whatever milligram per kilogram dosing you're going to do, whether you're using Versed, ketamine, etomidate, whatever you're using for a sedative hypnotic, and then for paralytic, if you're using succinylcholine, rocuronium, whatever you're using, know that dose and make sure and give enough. The other thing is there's plenty of papers out there, including one recently, that people remember the process, remember being intubated, remember being on a ventilator, and they're awake and you just don't know it. So not to get too off into the weeds about meds, but you got to make sure there's a sedative on board initially, and that if that person starts to wake back up en route, again, know your drugs. That person needs another adequate dose of sedation before you think about reparalyzing. So know the drugs you're using, do it based on weight. Try not to make one standard dose for everybody. That's what I can say about drugs.
I might add, in my own personal practice, the harder the intubation is going to be, the more I want the paralytic to work. So the concept that we're going to underdose a paralytic because it's going to be a difficult airway is 180 degrees the wrong direction, at least with regards to the way I practice. And I've seen that in the past, and I don't think it works.
Your first attempt is your best.
Your first attempt, your best. You're jumping out of an airplane. You're pushing your patient out of an airplane. Get it right.
Yeah, you got to be committed.
All right, so please understand this comes from a kind and gentle place. It really worries me if I hear people say something like that. Oh, let's just go low on that dose of paralytic because we're a little worried about it. No. Either they're going to sleep. They're going to go to sleep or they're not. And the enemy of you getting the tube in is tone. Okay, so you have it's either like being pregnant. You either are or you're not. Paralyze them. Go big on that dose. Go big on look at the like Lasux, couple mgs per kg with rock like high end 1.2 per kg. And go big on those dosage. Really watch, as Dr. McKinney said, the sedative hypnotic. Get it right. If you haven't read that paper, it's right. Yeah. So drug dosages confirmed and drawn up. Draw those things up and have them ready. All right. Inline stabilization required. So if the person's got a let me back up. We don't intubate anybody we don't intubate with a C collar on. I'll just give you a core concept. The part of your head that moves is your mandible. During laryngoscopy, you needed to be able to distend your mandible. The tongue is moved into the floor of the mouth of the submental space by the laryngoscope blade. These laryngeal structures move anteriorly against the collar. So we take the front of the collar off. This allows us, A, for these structures to move and us to be able to accomplish the procedure. 2, it allows us access for external laryngeal manipulation or cricothyrotomy, as Dr. Russ is pointing about. So front of the collar's got to come off. If we need to maintain inline stabilization, somebody's going to be appointed to that. What am I missing?
Yeah, no, that's the key behind this is obviously if the patient's a combative trauma patient, you're going to wait till you give some sedatives and hypnotics until they stop moving to take the front of that collar off. But when you're ready to go and someone's holding inline stabilization, take the collar off, attempt the first time. Now, on to pre-oxygenation. So I'll let Dr. Russ talk a lot about pre-oxygenation, but as you're going through this process of getting your equipment out, going through the checklist, a really good time to really start pre-oxygenating patients. If you think about who's going to have a peri-intubation cardiac arrest, it's hypotension and hypoxia are the two biggest indicators for that, right? Correct me if I'm wrong. So to say their SATs are 60%, we just need to get them intubated. While that is true, you got to try to get them up the best you can before doing that. We had a conversation in trauma conference yesterday about when do you decide to go in somebody who's hypoxic. And I think, I want to get Dr. Russ's opinion on this. My answer to that is if you start with SATs of 60, you're going to put on high flow nasal cannula, you're going to put on a non-rebreather. If you're bagging, you're going to bag. And ultimately, you're going to get to saturations to a point where you see they're not going up anymore. So if you go from 60% to 90% and you've been stuck there and you're not getting any higher, it's probably the best you're going to get in time to go. But don't get into the trap of saying Sats are low, I need to intubate now, go ahead and push drugs. That's a setup for peri-intubation arrest. So
Yeah, this is like altitude when you jump out of the airplane, right? You you want to give yourself altitude. Why not? Give yourself time. And so this is one of the places that I've seen a change in practice in the 15 years that I've been doing this. The nasal cannula, high flow nasal cannula is that's a game changer. And we can, Kevin, you want to show that there?
Yeah,
It
so-
is huge.
Yeah, so I've got on our 7 Sigma, I've got nasal prongs on. I'll be honest, just as a side note, Dr. McKinney was talking about us being vaccinated and having the mask on. I'm like pretty. I don't like using the cannulas that have got the end-tidal capability, because what I want is I want to be able to put 50 liters up that nasal prongs if I can. These tend to have really small orifice, and you're not able to get a super high flow rate with it. But so the minute we put eyes on the patient and we think they're going to need an airway, the prongs go on, the mask goes on, and ideally, both the O2 settings for both of them are as high as the patient will tolerate. And if I have somebody that needs a job, I'll just have somebody just take one finger just like this and just hold the mask on the patient. And now pre-oxygenation's underway, and we can be working through all this other stuff, as Dr. Russ meant.
another note, because I know there's a lot of astute providers out there, and there's a lot of literature out there on the harms of hyperoxia. And so I want to separate two thoughts here. One is the give yourself altitude thought, right? And then there's the after you're done with this procedure. So we know hyperoxia is bad for post-cardiac arrest. We know it's bad for MI. We know it's bad for closed head injury, right? Too much oxygen is bad. However, when you're intubating somebody and you have not gotten that tube in, give yourself altitude, right? You can dial back. After you confirm placement, you can dial the oxygen back to make sure you maintain sats that are appropriate. You don't have to be at 100%, but in the setup, give yourself as much runway as you can. So
Yeah, it's so safe apnea time. I want that. I want whomever. I want the proceduralist to have as long as they need. And as they've mentioned, this is buying me time. If you asked, in the years I've done this, the things that are the most game changing, I would agree with Dr. Russ, APOX, video laryngoscopy, real training and myth busting. But I'll still run into old teaching that kind of gets perpetuated. Good training, video laryngoscopy, and APOX are just complete game changers. So we're doing this on every patient. So we got the pre-oxygenation underway. All right, patient position optimized. So it depends on where we're working. And so if we're in the ED, we can do a lot more than we could do in a transport vehicle. You want to talk about here, hit on that?
yeah, so again, I freely admitted earlier that this is an easier procedure for me in the department than it is for you guys out. So to Kevin's point, there's not as many opportunities in the field for patient positioning, but there are some. You have somebody laying on the ground in the bathroom, they're not optimized. Get them on a stretcher, get them somewhere where you can get it bed at a better level if you need to, and they're not a trauma patient. If you need to raise the head of the bed a little bit to get ear to sternal notch or to get a large abdomen off of the chest, right, to allow you more time, do those things, right? If the patient needs to be scooted up in the bed so they're closer to you because they're hanging off the end, do that. We talk a lot about patient positioning, and if it's a non-trauma patient, you have time. If you need to put some rolls under their shoulder or do something you need to get better airway alignment, do those things before you start. So Dr. Russ, thoughts?
Yeah, totally agree.
Let me give you some, I'm going to call it transport specific things on positioning. I don't care what. So, towel roll, shoulder, or whatever you have to do to build a position where that patient has got ear to sternal notch.
Oh, yeah.
Oh, yeah. Okay. So,
Liz, you want to stop sharing for a second?
yeah. All right. So whatever you got to do to build this position, whether it's towel rolls, blankets, your partner's coat, whatever, you build this ear to sternal notch. So Jerry, just kind of come down a little bit. So the external auditory meatus and the suprasternal notch here are on a flat plane, just like that. Then I want their facial plane parallel with the ceiling too. Okay.
So that means if you needed to put something up under their shoulders,
exactly,
right, to get that sternal notch up a little bit,
yeah,
you do that. If you need to raise the head of the bed a little bit in a non-trauma patient, right, you have
yeah,
the opportunity to do that.
So if I can do that, that's what I'm going to do. The other thing is just in general, head up, facial plane parallel to the ceiling does a couple of things for me. It's going to help with oxygenation. It's going to if I can get their feet down, I can get their gut off their diaphragm. It's going to help me with oxygenation. Another thing is going to get the stomach lower than the airway, which remember, once we push that paralytic, all that smooth muscle is going to relax. Fluids are going to freely transfer back and forth. And so having the head up is going to keep those fluids down there where they belong and not kind of coming up into my airway. So the last thing is, we're limited what we can do with the patient in the ambulance. The other thing is like with Dr. Russ and Dr. McKinney, they can adjust the head of the bed, which which is awesome. All right, here I have to adjust my body habitus to where the patient is. I can't make this go up or down. So a general rule of thumb is I want the center of their head somewhere between my xiphoid and my belly button. I know I spent like 3 years with one EMS service working out of a van ambulance, and the stretcher was fixed, and I would have to kneel in the back of the ambulance every time I had to intubate. Versus some places, it's got a bigger captain's chair. I can maybe kind of perch on the end of the seat. I could do that in an EC-145 helicopter, but all of us are different, and you're going to have to kind of find some kind of, might be a yoga position, have to get yourself into to be able to intubate and manage the airway.
Yeah, and just remember that, as I said kind of when we started this optimization of the patient, that also includes where you're going to do this procedure, not just once they're on the stretcher, but you're really going to have to think, do I do this in the house? Do I do this on the road? Do I wait till we get in the back of the ambulance? Because that's going to help you optimize as well. I think we all kind of, the overarching theme behind having this checklist is being prepared. I know part of being prepared is not rushing into this procedure and kind of thinking about these steps. Super important.
All right, Liz, can we go back? I think we've got this last checklist item. We've done positioning. Yeah, Dr. McKinney mentioned it. So we'll make sure, we'll take that, if we've got an automated non-invasive blood pressure cuff on the arm, we want to make sure that that's not on the arm, that we're going to use that IV. So, and I can't tell you how many times I've seen it, is that, the non will go up right when we're starting to push drugs. So once we do that, our checklist is complete, and we can go ahead and move towards intubating the patient. Just some kind of other little tips here. What I've found is, so if I'll reverse roles with Dr. McKinney, and so I'm going to be his partner. Yeah, and so if I'm going to be the one to push drugs, if I'm sitting there holding, what I'll do is I'll make eye contact with the proceduralist and say, "Are you ready?" Yeah.
We can actually probably stop the slides. We can talk about outcomes here in a minute, but let's go ahead and stop sharing for a minute.
Okay.
We're going to have time for questions.
Nah, probably not. We're probably going to talk outcomes and then answer questions. All right. So a couple of other little small things. If I'm pushing the drugs, I'll look at the proceduralist and I say, "Are you ready?" And I want to hear them verbally confirm. And then I'll go, "Okay, here goes the, whatever the sedative hypnotic it is. Then here goes the paralytic." And then I start watching the clock and watching the patient for fasciculations or whatever for it to be go time.
I want to mention the sterile cockpit rule here.
Yes.
This is, I'm a pilot. This got drilled into me early. It's really important that there not be a lot of extraneous things going on in the room or in the back of the transport vehicle when this, once you've gotten to this point, really you should start it at the time of the checklist. But once you've pushed drugs, there doesn't need to be any other conversation. Like sterile cockpit, unless it's an emergency, you can wait to call out other things, say other things. 100% focus. You just push your patient out of an airplane. You got to get them to the ground safely. It's number one job.
So we don't have time for questions. So I will say that after we instituted this, we saw a significant decrease in complications. We did not see, and correct me if I'm wrong, Kevin, we did not see an increased time from pushing those medications to the time the patient was successfully intubated. In fact, that time went down. So there's some concern that if you institute a checklist, right, it's just going to add to the time of the procedure. It actually did not. So not only did we see better success, fewer complications, we also saw decreased time to intubation. So there's a question in the chat, and then we can go on to some more questions about having access to these materials. This is going to be recorded and posted within a week or so. Liz, you can correct me if I'm wrong. And then we will also
Dr. McKinney, we lost sound. Just stand by, everybody. I think that they're working on something to get the sound back.
we can hear you now, Liz.
I lost the mic.
I think I can
Hey,
hear you
Liz.
now.
We can hear you now, Liz. Go ahead.
All right, y'all go ahead. Y'all good?
Hey, or put it in the Liz. Put the question in the chat if you can hear us.
So there's one question about getting a copy of our Airway checklist. So that'll be posted. This is the same checklist that we use across from emergency medicine. Very basically the same as Life Flight. When I fly, it's in my right pocket, right there on the leg. Pull it up.
All right, so we're going to give you option. We'll post these. Like I said, the other option is you can contact me. And I'm happy to be available. You can see my email and Dr. McKinney. Well, my email is not on there. Just Google Kevin High Vanderbilt. Or Dr. McKinney, you can find us. Jerry said that they're going to post this on Facebook, the entire video too. But we're happy to share materials. Liz, if you got any other questions?
No, just a few comments, or if y'all are wrapping it up. There's one, wait, there's one more.
Say that one more time.
There's a question in the chat. Can you all see it?
Stop sharing the screen.
What's the question?
Hold on, I got it. I've heard that a fall in oxygen with sequential intubation attempts falls more rapidly. Can you speak on this? So I think what this is the question is the drop in oxygen on second, third, fourth. I think that's totally true. That
Yeah,
you're never going to get a better chance than the first one.
Yeah. So I think they might be referring to the paper that Dr. John Sackles did that looked at risk of hypoxemia and adverse events with sequential attempts. And yeah, I mean, it just, especially when you get past a second attempt, it's, I mean, it's unbelievable. So I'm glad this person asked that question. Let me ask you, and I'll just, it's a rhetorical question because I know what they're going to say, but I'd ask you, what is an attempt? And you need to know that, you need to know this. So for us, an attempt is if a global overarching goal should be, you want to make the least amount of attempts.
Be a number for you once there's a lag in the pulse ox and you've already fallen off the curve. So, and I think one of the traps you get into is I'm almost there, I can see it, I'm almost there, I can see it, even though you're less than 90%, and you keep trying, and then suddenly you're in the 50s. There was another question about leaving a placeholder. Whether you intubate nasally or you intubate through the mouth, if you end up in the esophagus, the question is, do you just keep that there as a placeholder? There ends up being too much near the face or mouth to do that. The other thing is the esophagus can dilate a lot. You could probably fit quite a few tubes in the esophagus. So if you intubate and you put on end tidal, you don't have end tidal, you're not in the right place, you need to pull that, oxygenate again before you make that next attempt. So
There's
go ahead, Dr. Russ.
Well, there's another question about nasal intubation and why not do nasal intubation. Then if you don't get it the next time, you can put it. You want to talk about, should we talk about the evils of nasal intubation? So the things that come to my mind is you're definitely going to have to reintubate that person because you cannot take care of a patient in the ICU for any period of time with the nasal tube in place. The morbidity around what happens to your sinuses in your face with more than a few hours of having a tube in place. Next thing I'd say is that the trauma that you can do with an ET tube, it's unbelievable what I've seen this do to the inside of people. I've seen it pushed into the mediastinum from blind attempts. I've seen people with just completely macerated. The number one problem with me from a standpoint of the nasal intubation is you're going to be stabbing blindly and creating a tremendous amount of erythema, edema, fluids with anything other than the very perfect slide in the first time. This isn't really designed to do that. If you're going to do a nasal, I think if you're going to do a nasal intubation, you got to do a fiber optic.
Yeah. There was a comment too in the chat about, it may not have been clear, we were talking about what the definition of an attempt was. Once you put that blade in the mouth and it crosses the incisors, you've attempted, whether you try to pass a tube or not. We defer to medical direction in your service, but for us, once that blade goes in the mouth, that's an attempt. And you really need to try to limit your number of attempts. You also need to have, again, what's your bailout? When I get to what number, am I going to say, absolutely, we're stopping and we're bagging back up?
So let me hit on the nasal intubation thing. Listen, this is a kid of the 80s. And if you live in Middle Tennessee, see anybody walking around with a really big right nair and a normal size looking left nair, they probably met me somewhere between 1985 and 1995. But all the literature on it, as Dr. Russ says, the best is 2.5 attempts for success. There's a ton of downside on this. And the other thing is all the patients in the ICU, we can't manage them. They all get sinusitis. I've seen these. I've seen one in the brain. I've seen them everywhere. And if you don't mind me, hand me that. Just look at the bevel. That hard bevel right there will really do damage. And I'll tell you, we're the, I don't know, fourth, fifth busiest trauma center in the United States. I haven't seen anybody nasally intubated in the pre-hospital setting in 2 years.
There's another question up about sealed airway.
So anyway, I feel very nostalgic about it, but The other thing, to Dr. Russ's point, nowadays with fiber optics, there's a hard argument, and this brings up all is fiber optics going to ultrasound? Why go blind when you can see? Is us blindly doing procedures now is just, it's getting harder and harder and harder to make an argument to do that. And as Dr. Russ talked about, is you can get into a fiber optic device pretty cheap, and one complication will cost you a lot of money. But anyway, what's this?
There's a question about seated versus standing
Yeah,
intubation.
yeah.
Thoughts on
So
that? I do all mine standing.
Okay, so I'll just say it just depends on your body habits. And so, I'm running a cadaver lab at Vanderbilt. I've got 300 and something students passing through there a year. And so all of our tissue is it's just like an EMS stretcher. It is fixed. I can't move it up or down. So what I'm having the learner do is they have to manipulate their body to that. Whatever works for you is what you need to do. I'm sitting in this captain's chair. I could slide this up a little bit. I can be on the edge of the seat and do it. But now somebody that's, I don't know, 75 pounds bigger, 5 inches taller than me probably can't. I think it depends on your body habitus, what type of vehicle you're working in. I know there's a lot of different aircraft configurations. I would say the worst thing, especially if you're doing DL, is having, and I've seen it in some of the single engine platforms where the patient's head is like literally between your legs, and trying to do direct laryngoscopy is almost like you're looking down straight over, standing in the street looking down a manhole. You need to be where you can get back away from the head and get a line of sight here. And it just depends on what kind of vehicle you're in and what your size.
What about, Kevin, what about patient sitting?
Yeah. I mean, okay. So patients sitting up. All right. So I'll tell you, if you look at all the anesthesia literature on these bariatric patients. So we'll have, I know at Vanderbilt, we'll do like a lot of bariatric surgery on a couple days of the week. If you go in there, they're intubating all these people sitting up, and they're 45 degrees at least. The two things: they got to get their diaphragm, got to get their gut off their diaphragm. They've got to get gravity helping, pushing everything down like this. And yeah, I mean, I think it's definitely helps you with oxygenation. I am not a fan. I've had a couple of really bad experiences of intubating people in cars. They're trapped. I'll just tell you, I'm not a fan of all that tomahawk stuff. Not a fan.
I will say the other thing is if you're going to do more of an upright position, we won't say seated, right? Because this truly isn't seated, but if you're going to do more of an upright position, you may need something to keep that face parallel. And you may need to pump things up, shoulder and so on. So again, you unload the diaphragm, which is immensely helpful. But if you're going to do that, don't forget this part of the patient as well, and making sure that you're still trying to do ear to sternal notch and parallel face planes. Minutes, one or two more happening answer.
You do think there are or not?
All right, well, hearing none, we don't see any other ones in the chat. We obviously love talking about this stuff, so you can get our contact, and we're happy to answer questions. We'll send out the video link for this, as well as look at distributing the checklist if you're interested. So thank you all for being here. Hopefully it was helpful, and we'll do it again soon.
Thank you.
See ya.
Thank you all. It was wonderful. For you all on the call, please, if you haven't already typed in your email address and your name, please do so, so that we can send your certificate out. You should have those from Bo or I by Friday. The next thing I wanted to share with this group, if you haven't seen it, the iServe conference information is out on our webpage. It's also on Facebook. That conference is August the 26th and 27th. We're excited to say it's at the Graduate Hotel on West End. A lot of good things to come, live music and a lot of great speakers for that. It's August 26th and 27th. So don't wait too long. We're expecting to sell out. We already have like 80 or 90 people registered, and we'll be taking 220 people. So again, August 26th and 27th. Thank you all for joining us. See you soon. Hi, Jay Nance. I didn't know you were in there.
Hey, Liz,
Yes, ma'am.
I'm not sure I got my email address to you. I've never sent something through chat before.
Just, do you see how to in the chat box and you just type it in there?
Yeah, I thought I sent it to all panelists. I typed it in there and hit enter, but
If you did that, it's in there. There's just so many going off right now. I can't check them all. So,
well, if I don't hear from you, I'll email you later.
okay. Thank you.
It's good to see you.
Good to see you.
Bye.
Bye-bye.
Hey, Liz, I'm not able to get mine in either.
Is this Amy?
Yeah,
Okay, we got you.
thank you.
You're welcome.
See you guys.
Wake up, Jeremy. You're muted. I can't hear you. Your sunglasses are on, so I can't hear what you're saying.
I had eye surgery Friday, and it is rough. So no,
Well, good.
it's
I just thought maybe you were trying to be funny with your eyes. I'm glad you're okay.
no ma'am. I have to keep looking away every so often, but it's pretty rough on this screen. I have to take pictures and blow things up just to see print. So no, it was a wonderful little lecture. I greatly appreciated it.
Well, good. I'm glad you're doing good. Good to see you.
Thank you.
Thank you. It was great.